My name's Elaine Husney. I'm a rheumatologist here at the Cleveland Clinic, and I'm going to introduce our next speaker, who is Dr. Stan Cohen, who has been a professor at UT Southwestern Medical Center, but many of you would know him in his illustrious career. He is also past president of the American College of Rheumatology, so he has led many of us over time, and we're really excited to have him to talk about more personalized care in RA.
Let me get oriented. Good afternoon, everybody. It's always tough when you get the lecture after lunch. But Lynn invited me up for dinner, basically, and said, okay, if you're going to come, you need to give a talk. And so I'm a clinical trialist. I'm also a clinician, see lots of patients. And so this is a little bit different exercise for me, but it's been a great interest. And we have been struggling for years to advance rheumatoid arthritis therapeutics with more precision medicine. So I'll summarize where we've been, where we may be going, and what our status is in the future. So like all of us now, I went to ChatGPT and said, okay, tell me about precision medicine and RA. And I understand we're already 4 iterations past this now. Could put this lecture together certainly better than my rudimentary PowerPoint skills. But again, precision medicine uses a personalized approach to diagnosis, treatment, and management of disease. And we're now using genetic, molecular, and environmental factors to tailor treatment plans. So again, this is the 40,000-foot view. I actually heard my first lecture on precision medicine, what used to be called personalized medicine. Now there's somewhat of a stigma against personalized, but with some more precision medicine in 1985, and thinking that we would be, farther along than we are at this point. But I have, and I'm sure you have as well, have been very jealous of our oncologists for many years. There have been 2 major breakthroughs in oncology. The first was after World War II with cytotoxic anti-tumor drugs and the birth of chemotherapy. And then in the 1980s, basically the use of molecular pathways, cellular biology studies on tissue or blood to come up with targets that can be addressed in oncology in a much more specific way for individual patients. This is a little cartoon from a review and shows the receptor tyrosine kinase, characterized by many different receptor tyrosine kinases, but the one we think of most often is like in breast cancer, the HER2 receptor, which can be inhibited by trastuzumab, Herceptin, and has improved disease-free survival by 25 to 30%. There are multiple intracellular tyrosine kinases that can also epidermal growth factors, VEGF growth factors, that can be targeted in oncology in a specific way based on what's found at the time of biopsy, looking at the tissue, or looking at cellular DNA, RNA findings. So tremendous strides have been made in oncology, as we all know. And then in our field, going back just a decade ago, our good friends Daniel Ataha and Joseph Smolin wrote an editorial on annals of rheumatic disease, forget personalized medicine, and let's just focus on low disease activity and remission. And their hypothesis was that we have these different studies taking a look in TNF inhibitor failure patients, whether you go do a second TNF inhibitor or go to abatacept, rituximab, or tocilizumab, and you look at the ACR50 response on the y-axis here, and basically the results are the same, regardless of which therapy you pick post-TNF inhibitor. And then this little cartoon over here says these are all what we know about the pathogenesis of RA, the cytokines involved, the cells involved, but they all funnel down through IL-6 and TNF. So let's just aggressively block these cytokines and we'll control disease best we can. But things have evolved, and we now in the age of omics, and we have multiple different ways of looking at genomics, sequencing RNA, transcriptomics, proteomics, and so forth. And utilizing that, we're beginning to, in association with things that are a little bit over my head, machine learning, artificial intelligence, develop some biomarkers that may have some utility. So let's look back at the groups that have been involved, and I'll go over some of the previous data looking at simple things that may give us some idea of treatment response. But there have been groups that have been looking at the synovium. 2008, the pathobiology of early RA consortium was put together, and they've done seminal work, and I'll show you some of their data. And they've led to the discovery that three major synovial pathotypes or endotypes, and lymphomyeloid, diffuse myeloid, and polycythemia, which we'll discuss in some detail. And then 2012, the UK MAP Consortium has been working to map clinical responses to immunological profiles. And then more recently, the NIH and IAMS initiative, the AMP partnership, Accelerating Medicines Partnership, has been using RNA sequencing, single-cell RNA sequencing, single-cell analyses from synovial tissues, which have demonstrated that there are multiple different types of cells involved in the RA pathogenesis, different types of fibroblasts, different types of macrophages that could potentially be targets moving forward. So we'll discuss that in some detail. So the areas we want to talk about first is the rheumatoid factor, ACPA positivity, seropositivity, shared epitope positivity, and what role that might make on response to certain therapies. We'll talk about the role of synovium on treatment selection. We'd have one slide on Dana Orange's work with prime cells, which are found preceding flares in RA, and then talk about what really may change things in the clinic eventually, which will be liquid biopsies. And this, such as the PRISM RA, which is under development, and other companies looking at cell-free DNA. We heard Dr. Shett mention this morning about the garbage in the blood, the system from apoptosis and so forth. We might utilize that garbage to better understand biomarkers that might allow for better treatment selection. So I was involved and fortunate enough to work with Rituxan and helped rituximab get approved for rheumatoid arthritis in 2006. And we noticed in that study, and I was involved in the reflex trial, which was TNF incomplete responders, that patients who were seropositive had a greater delta DAS response, a better clinical response than patients who were seronegative. And that's shown here on this forest plot. And we also saw a similar phenomenon in the IMIDs trial, which was methotrexate naive patients, that seropositive patients had a greater delta DAS than seronegative patients. And when you took a meta-analysis, which John Isaacs did, and I was on this manuscript as well, we saw a trend that seropositivity did impact response to rituximab, which, you know, at the 40,000 foot level, you're knocking out B cells, plasmablasts, and eventually plasma cells and reducing ACPA production. Whoops, here we go. And then around that same time, collaboration of registries in Europe, 10 different registries, took a look at patients who started on rituximab, either after TNF failure or after CS-DMARD failure, and they took a look at patients on the top left who were rheumatoid factor positive, top right, ACPA positive, and double positive on the bottom. And what you can see, the y-axis is the delta and the change in the DAS score, and you can see that for seropositive patients, there was a better DAS response than in seronegative patients. So modestly predictive of response. So we still utilize this data, but the reality is rituximab in RA, in contrast to vasculitis, is really more of a salvage therapy. So we will end up treating seronegative as well as seropositive patients. But the data suggests that seropositive patients, certainly double positive patients, may respond to rituximab in a superior fashion. So the AMPLE trial was the first head-to-head trial of biologics. And this was in CS-DMARD failures. They were on methotrexate. And it was abatacept versus adalimumab. And the 646 patients randomized and treated. The majority completed 12 months. And when the dust settled, well, actually, this is the patient demographics here, and 75% to 77% were rheumatoid factor positive. And actually, when this paper came out, at the time, they didn't even put the ACPA data in there because it still was not quite at the forefront. But later on, it became clear that about 75% of patients were ACPA positive as well. And these patients had about 2 years of disease. And when the data was analyzed, there was no difference. So we all put up our hands. Here you go again, another biologic. No one biologic is better than another biologic, and so be it. But about that time, data came out and was looking at the shared epitope, the class 2 MHC molecule, which presents antigen to T cells, and demonstrated that citrullinated peptides were more likely to bind to the P4 binding pocket than non-citrullinated peptides. And therefore, You'll have greater antigen presentation, more upregulated T cell activation in the presence of citrullinated peptides. So the company behind abatacept said, well, maybe if we go back and look if ACPA positive patients may have a better response to a differential response from adalimumab with abatacept. So Jeremy Sokolov, who was at the company at that time, did a post hoc analysis of the AMPLE study, which I just showed you. And what we have here is CDI remission and DAS28 remission. And we have the percent of patients on the y-axis, and we have day 365 and day 729. It's hard to see, but they broke down the ACPA titers into quartiles, so either negative or 4 quartiles. And patients at the highest quartile of ACPA, at greatest titers, had a much more robust response to abatacept compared to adalimumab. Adalimumab, the response was really no different with whatever level of ACPA titer you were at, but there was a differential response with abatacept for higher titer ACPA patients. Gottenberg and colleagues, again, another compilation of registries. This is 9 different European registries, looked at the retention on abatacept between seronegative and seropositive patients, and showed that overall there was a slightly greater retention on abatacept in seropositive patients than seronegative patients. So supporting the hypothesis that possibly abatacept might have somewhat better response in ACPA positive patients. So our good friend William Rigby published a trial. It was a pilot trial looking not only at ACPA positivity, everyone was required to have high titer ACPAs and be rheumatoid factor positive, but also looked at the shared epitope, the DR beta 1 risk alleles, and to see would this enhance the response to abatacept compared to adalimumab. A single blind study, small study. This was the study design. These patients were biologic naive patients, and they were on background methotrexate and either received sub-Q abatacept or sub-Q adalimumab for 6 months and then randomized to abatacept open label. Again, just to point out, they had very early disease, symptoms less than 12 months. They were enrolled in the trial if their ACPA titer was greater than 3 times the upper limit normal, and they were seropositive for rheumatoid factor. The primary endpoint was the proportion of shared epitope participants meeting the ACR 50 response at week 24. This is the patient characteristics, and just want to point out to you the very high ACPA titers in this trial, around 1,000. As you would expect in ACPA positive patients, 75 to 80% are shared epitope positive here. It was interesting taking a look at the patients who had the shared epitope versus those who didn't. Much higher CRP levels, much higher ACPA levels, and higher rheumatoid factor levels as well. So here are the results, and you can actually look at the hard numbers down here. There was enhancement for all patients of abatacept in blue compared to the brownish orange adalimumab for ACR 20, 50, and 70 at week 24. So being high titer ACPA positive, there was a greater clinical response to abatacept than adalimumab in this trial. And when you take a look at the patients who were only shared epitope positive, numerically there was also an enhancement of the clinical responses to patients who had the shared epitope plus ACPA positivity. So looked like there was a signal here that patients who have high titer ACPA, shared epitope positive, may respond better than a TNF inhibitor post methotrexate. So that led to this study, which is enrollment's complete, analyzing the data, a much larger early AMPLE study called the Amplified Clinical Study, which is a phase 3b randomized study, again, in very early seropositive RA patients who are shared epitope, have shared epitope risk alleles and inadequate response to methotrexate. So we look forward to this. And so what we have is we have suggestion that rituximab may be better in seropositive patients and abatacept may be better in high titer ACPA patients and patients who have the shared epitope. So a little bit of a movement towards some movement away from our imprecision that we now have with our empirical decisions in managing rheumatoid arthritis. So let's talk about synovium. the group that I mentioned from Europe, the consortium that basically has come up with these different pathotypes in RA based on biopsying 200 patients who had early arthritis, either early undifferentiated arthritis or met the 2010 criteria for rheumatoid arthritis and so forth, have come up with 3 different pathotypes. Lymphoid myeloid, which is B-cell enriched, along with macrophages as well. Diffuse myeloid, more devoid of B cells and more macrophage driven. And then this third group, this fibroid PsA group, which is more stromal, very acellular group. And again, these synovial biopsies are done primarily on the wrist or a finger or a knee, and these are done by ultrasonographers who are proficient. I know all of our trainees now get ultrasonography training, but I know many people get in the real world and don't do it very often anymore. And these people have all been trained to do synovial biopsies with a very small needle. So what they demonstrated is that they took a look at these different pathotypes, and they found that the group that met both the 87 and 2010 RA criteria more likely were lymphoid myeloid than PsA or diffuse myeloid. And these people were more likely in their synovitis to have much higher enrichment of the various cells, which we just mentioned, B cells, plasma cells, and macrophages. The undifferentiated arthritis patients were more likely to be a mix of diffuse myeloid or PsA immune. And then as far as persistence of disease shown down here, when they followed the patients, the lymphoid myeloid pathotype and diffuse myeloid were much more likely to have persistent disease than the PsA immune. So for the first time, telling us that information from the synovium can provide some information on what may happen to patients from a prognostic prediction basis. They also went further and they came up with a model to predict going on biologic therapy for these patients. And they had some features which were clinical, CRP, total joint count, DAS28, and then they looked at RNA sequencing and genes transcriptomics in the synovium. And what they found is that just with clinical features in the black line, you can predict the majority of patients who will go on biologics. But if you add gene expression, shifts the curve to the left, and you have a more sensitive analysis showing that synovial gene expression may help us understand which patients are going to be need to be more aggressively treated. And then this very exciting work that again, our European colleagues have conducted with the PsA senior author. And this was the R4RA study. And this was rituximab versus tocilizumab in rheumatoid arthritis patients. And these are patients who had failed TNF inhibitors, who were then randomized, depending on the level of B-cell enrichment on their synovial biopsy, to receive rituximab or tocilizumab, and then they were followed initially for 16 weeks and then longer. And again, we have our pathotypes, which we've previously shown you. And initially, when they looked at histopathology, the data wasn't too exciting. They really couldn't differentiate who was going to respond to tocilizumab or rituximab. But when they went further and did RNA sequencing, deconstructed the synovium, and looked at gene expression markers, what they found is that in the diffuse myeloid population, tocilizumab was much more effective in treatment response in this population. And in the lymphoid myeloid, more B-cell enriched, there really wasn't much difference in this population or the PsA immune, suggesting that gene expression data might, again, enhance our knowledge of who's going to respond to what particular type of therapy in a more refractory patient who's failed TNF inhibitors. Oops. They drilled down a little bit further, and again, looking at this is a 50% improvement in CDAI, and for patients who are B-cell poor and macrophage and myeloid dendritic cell rich, tocilizumab was far superior to rituximab in this population of patients. And Laura Donlan, in the editorial that accompanied this, raised the issue that, again, if we have a patient with low B-cell signature, high myeloid signature, that, possibly an interleukin-6 receptor inhibitor would be best therapy, and avoid B-cell inhibitor in those patients. So extremely exciting. And not only did they demonstrate this, but they went further and did, again, modeling using machine learning and came up with a model that could predict, based on the initial synovial biopsies, what patients were more likely to respond to therapies. So again, so moving in this arena, we'll talk about the practicality of this or not. Mike Brenner shared this slide with me. And again, this is the same study. And what they did is with patients who failed to have a 50% response in CDI, they were retreated with the other therapy, tocilizumab to Rituxan, Rituxan to tocilizumab, and some response and some did not respond. And they ended up with this refractory population of patients. So refractory to tocilizumab, refractory to Rituxan, and refractory to TNF inhibitors. And when they did gene expression analysis, what they found is this population of patients were enriched for fibroblast genes and extracellular matrix genes. So this work, along with the work from AMP and the suggestion that there are multiple different populations of fibroblast in the synovium and this refractory population may lead to therapeutics in the future going after the fibroblast population in contrast to things we've done in the past. So extremely exciting. But is it feasible? I mean, in the real world, I'm a clinician still seeing too many patients, too many days a week. You've got to be a great ultrasonographer, and you need to learn how to do these synovial biopsies. And to like anything, to be proficient, you got to do them over and over again. I understand from Harris Perlman and others, Northwestern, which is the center in this country that's really pushed this, the learning curve takes a while. What if we have a patient there and we're trying to figure out what therapy to put them on, and it takes 2 months to get the results back? Because there are only certain centers that can do this type of thing. So, I'm not sure how to get over that hurdle. Cost concerns will always be there. Now, where I think this has tremendous hope and validity would be in the early phase research. We do a lot of first-in-man phase 1 research at our center. And there's a lot of therapies out there now. And you've got to be better than what's on the market these days. Me Too drugs are gone. So if you're in early phase research and you're trying to make a go, no-go decision about a new therapeutic, it would be great to have some gene expression data, looking at cytokine production, whatever, to guide your research. And I've heard it said in pharma companies, we're not going to develop a new therapy unless we have a treatment biomarker to go with that therapy. Because right now we're doing the old Andy Griffith way for you guys who are old like me, just beating on the desk and, well, I'm going to pick this drug. I'm going to pick that drug. So I think in early phase research, synovial biopsies may make tremendous sense. So just shifting briefly to Dana Orange's work, which was incredible, where she took 4 RA patients and had them finger stick themselves several times a week. And then she did RNA sequencing on the blood samples that she had. And she noticed that there was a change prior to and during flare-ups of rheumatoid arthritis. And then she felt that this was mediated by these pre-inflammatory mesenchymal cells. And what she demonstrated was that a couple weeks before the flare-up, these naive B cells were activated. And then about a week before the flare-up, these mesenchymal cells were recruited. And when she did gene expression analysis, the gene expression of these prime cells was very similar to sublining synovial fibroblast. And so she suggested what was happening, these cells were being recruited, trafficking to the synovium and becoming sublining fibroblasts. And she found this signal in 19 other patients as well. And so I don't know where we're going to be going with this data, but fascinating that you see the change at a gene expression level in patients preceding a flare and after a flare. So what about liquid biopsy? It's very hard to get tissue. We're not good at synovial biopsies yet. We don't have a cadre of people who can do them. So I don't know about you, but in my medical school, we didn't have an informatics class. We didn't know about machine learning and artificial intelligence, other than Dr. Spock and people like that, Mr. Spock. But we're here now. And with advanced computational approaches, combined clinical data, integrative genetics, we can now come up with modern precision medicine. There's whole literature of network-based approaches to understanding human disease biology, the protein interactome, and so forth, network medicine has evolved. And so this group, which I do consult with and have worked with, has been working on this for a number of years. And this is a paper which is fascinating, which I read 10 times, and I think I'm beginning to understand it. And basically, they've developed a blood-based predictive test for stratification response to TNF inhibitor therapy. They're looking for a molecular signal of non-response to TNF inhibitors. So what they did is they took a discovery population of 58 RA patients. They looked at like 20,000 transcripts and came down with a number of these transcripts which were discriminatory between response to TNF inhibitor and failure to TNF inhibitor. And then they enhanced it in a training population where they added SNPs and other transcripts and came up with 37 identified biomarkers, continued to refine it, and came up with a molecular response classifier, which has had a positive predictive value in the range of 90%, and sensitivity and specificity actually more in the 60 to 70% range, other than the 87% shown here. So this is from their slide deck, and basically these are the gene expression features, and they have 4 clinical features: actopositivity, gender, patient global, and BMI. And they are studying this, and I'll show you some of the studies in small numbers of patients and the results. And what was interesting, and again, a much more complicated process, years to develop, these are the actual gene expression markers that ended up in their assay, and a number of them are involved in T and B cell activation. They're involved in pro-inflammatory signaling, apoptosis, bone destruction, and are found. And when they looked at the protein products of these genes, they're very close together in this protein-protein interactome, which they looked at, which they call the disease module for rheumatoid arthritis. So what is this test? You can order it now. At this point, I'm not sure exactly what it costs. It looks in the range of $2,500 to $3,000, but I'm told, according to the thing on the internet, when I picked it, no patient pays more than $75. That's all I know about it. But it's a whole blood gene expression test. Again, I talked about how it was developed. The SNPs, the transcripts, the labs test, 3 clinical metrics. It requires 2 PAX gene blood RNA tubes and 2 serum tubes. And then they transfer the data on a scale of 1 to 25. And a score greater than 10.6 predicts non-response to TNF inhibitors. And in their various studies, in few hundreds of patients, it does increase the odds ratio for non-response. So it's either 3.4 to 8.8, 3.3 to 26.6. So you are potentially decreasing the likelihood that someone's going to get a therapy they're not going to respond to. This is the report that you get, and basically gives you the percentage of, if your patient has the molecular signal non-response, what the likelihood of them being an inadequate responder. So there have been various studies done. I was involved in one, actually a couple of them, and looked at different populations, TNF naive, TNF exposed. And again, the positive predictive value has held up. It's been about close to 90% predicting non-response to a TNF inhibitor, different levels of sensitivity and specificity. But what you'll notice, this is few hundreds of patients. This is not thousands and thousands of patients. They do have thousands and thousands of patients. We participated in a clinical trial. They even recruited 10,000 patients. So they're still wading through the data, and this is the data that we need to feel comfortable that this assay is truly predictive of non-response. It's something that would be of value in the clinic. So it has been pretty clear from most of the studies that have been done in these 800 patients that about 40% of patients have this signal of non-response to TNF inhibitor. We know the ACR50 with TNF inhibitors is about 30 to 35%. So this was a study, one of their sub-analyses of this very large 10,000 person study. You either had the molecular signal or you did not have it. And then at the bottom, we have patients who, even though they had the signal, even though they had the signal, still went on to TNF inhibitors, or they went on alternative treatments. These were the folks who didn't have the signal and were treated with the usual care. And what you can see is those patients who had the signal of non-response, only 10% had an ACR50. Patients who went into other therapies had an ACR50 of slightly over 30%. And patients who did not have the signal of molecular non-response had an even more robust response to TNF inhibitors. A second study looking at CDAI change, again, about 40% of patients had the signal of non-response. And what was seen, just to summarize all this down here, 43% greater improvement in CDAI in week 24 in those patients who were treated with an alternative mechanism of action rather than a TNF inhibitor. And so the summary from Mellers and the group is that drug response biomarker panel could have prevented half of these individuals from taking a drug that did not ameliorate the signs and symptoms of their disease. And then the other thing is, will it lower cost? You know, if we don't want to have our patients getting inefficient therapies, and this is some of their modeling, and we're always a little bit uncomfortable with modeling from the companies, but we'll learn more as we go along, and potentially there will be some cost savings here. So just to finish up very quickly, this is another company that's looking at cell-free DNA. I know you all know Illumina, you all know Grail, you heard about the garbage this morning that's in the circulation from the nucleosomes and so forth. And these folks want to carry this to autoimmune diseases and see that if they can look at the chromatin circulating, will it be a biomarker that we can use to monitor therapeutics. So last slide, there's a lot of hurdles for precision medicine RA. This is a polygenic disease with environmental influences and so forth. You know, I think we are making headway. We are not there yet. One of my favorite quotes of all time was from Churchill, if I don't butcher it. We're at the end of the beginning. I don't think we're at the end of the beginning yet. I still think we're in the beginning. And, but again, this is where we are with a very imprecise methodology that we have now. We're making some modest strides. So I'll be quiet and take any questions if you have them.
We do have our next speaker live online from Portugal. It's Dr. José Da Silva. He is a professor of rheumatology and the chief of rheumatology at University of Coimbra in Portugal. We're really excited to have him. He has a long-standing interest in prioritizing the patient's voice and continuing on the theme of personal and precision medicine. He prioritizes the patient's voice in their care and how we can learn improving treatment outcomes and enhancing quality of care. So I am going to have Dr. Da Silva on.
Thank you very much for introducing me. Thank you for inviting me to this very important meeting. It's really an honor to share with you my thoughts about how to try and put the patient first while trying to treat rheumatoid arthritis to target. Thanks to Professor Calabresi and to Elaine for this invitation. Now, my greetings from my university. It's one of the oldest in Europe, established in 1290, and there it is on top of the hill in our hometown. So I hope this will entice you to try and visit. And I would also like to share with you the motto of our department. It reads like promoting happiness through excellence of care. And I hope this conveys to you that our interest and focus on the patient's view on rheumatoid arthritis and other rheumatic diseases. The important point is that in order to make progress, we have, of course, as clinicians and researchers, use the resources of outcome measures. And for a clinician and for the physician's view of a patient in a given state, rheumatoid arthritis might be seen as a number of swollen or tender joints, perhaps the patient's global or pain visual analog scale, ESR, CRP, DAS, CDAI, SDAI, and X-rays. But for the patient, the experience of the disease is a totally different matter. For him or for her, RA is about feeling or not feeling pain, doing or not doing things, seeing people, enjoying life, being independent and depressed, making love or not making love, raising children, feeling tired, etc. So I think that as clinicians and researchers, we need to keep in mind that our markers of disease activity and progress are only as good as they are as surrogate markers of what really matters, and that is the patient's experience of the disease, both at short and long term. And the difference between clinicians and patients in how they score disease activity has been well known. And perhaps one of the most emphatic studies about that is one I'm about to show you. It relates to the International Classification of Function, Disability, and Health, according to which any disease could be classified in terms of problems related to body functions or structures, activities that the patient can or not take part in, and social participation. Now, the research has established the group of rheumatologists to try and establish the ICF core set for rheumatoid arthritis. And these experts came up with 76 categories of problems, 15 related to body functions, 8 to body structures, 32 to activities and participations, and 21 environmental factors in trying to encompass the rheumatoid arthritis as a disease. Later on, the same questions was presented to patients, and we are glad to realize that out of the 76 problems identified by clinicians, 74 were confirmed by patients. And it would be fantastic were it not for the fact that the patients came up with 66 additional points that needed to be considered in trying to understand the impact of the disease upon their lives. We have tried also to identify markers of overall enjoyment of life and how they are affected in patients with rheumatoid arthritis, establishing a lot of research on determinants of happiness and quality of life in people with rheumatoid arthritis using the structural equation modeling approach. We have used data for over 400 patients from our department, and we have come to the conclusion that, of course, one of the major aspects here is disease impact, which actually has a large impact on quality of life and happiness, much more than disease activity itself. These domains like pain, disability, fatigue, and sleep are much more important factors in determining disease impact than disease activity itself. Disease impact, as perceived by the patient, has a major consequence on quality of life, and not such a great one on happiness. Again, underlining that these are completely different concepts. Quality of life, as measured by EQ-5D, for instance, is actually focused a lot on mobility, ability to do things, and not so much on the ability to enjoy them or enjoy you still can do. From this point of view, from the point of view of happiness, understood as the overall enjoyment of life, taking it all into account, personality is a major factor. It has a improvement effect upon disease impact, meaning that it ameliorates disease impact if you have a positive personality as characterized by high levels of extroversion, agreeableness, consciousness, emotional stability, and openness to experience. And moreover, it has a very important impact on the overall enjoyment of life, namely on happiness, as we call it. What is this related to treating to target? And how can we see this patient's perspective in the current treat to target paradigm? I will address that in the treat to target in RA and its limitations, and also propose to you and express our dual target strategy proposal, namely the concepts and how we could use that in practice. I believe that we all agree that there has been enormous progress in the management of rheumatoid arthritis over recent years, and that these are essentially organized around three major domains: the ability for earlier diagnosis and more timely intervention, the development of new and more focused and target agents, and also the adoption of the treat to target strategy. And I think that we all agree that a lot of our improvement is actually related to the third of these items. So what do we mean by this? The idea of the treat to target strategy is that medications should be adapted regularly so that we achieve a treatment target as early and consistently as possible. This will be measured by consistent and validated disease activity. This is under a tight control. If the assessment of the disease activity determines that the target has been achieved, you continue with the treatment. If the target has not been achieved, then you should increment immunosuppressive therapy, increase the dosage of current medication, change the route of administration like methotrexate from oral to percutaneous, add glucocorticoids, add conventional IMIDs, or add biological untargeted synthetic agents. So this strategy gives an enormous importance to the definition of targets. It is absolutely essential that we know what we are trying to achieve, and that we have good reasons to select a given target. Now, what we have been placed in recommendations like this one from the EULAR recommendations from last year is that the treatment of RA should be aimed at reaching the target of sustained remission or at least low disease activity in every patient. On the basis of this, our patient population could be split into two groups. Either they are or they are not in remission. And then on the basis of this, we would then decide whether to maintain or increment their immunosuppressive therapy. It is recognized that for some patients, particularly those with long-standing disease, perhaps low disease activity as measured by one of the adopted disease activity scores would be an acceptable target. Now, ACR and EULAR has conjointly defined a few targets that could be acceptable, namely the SDI, definition of low disease activity or remission, a Boolean definition of remission, whereby tender joint count, swollen joint count, CRP, and patient global assessment should all be at a maximum of 1. And more recently, the Boolean definition has been revised by ACR and EULAR in order to accommodate a PGA threshold of 2 or less. So trying to make the rate of remission with the Boolean definition closer to what has been seen with SDI. The CDI definition has also been considered acceptable for clinical practice. So I underline here that all of them consider the PGA, the patient global assessment of disease activity. And what has been seen and demonstrated is that actually there is a very important group of people who fail remission solely because of one of the Boolean criteria. And out of this group of people that has been designated as being in near remission, by far, PGA is the most important factor precluding achieving targets of remission by only a single of the 4 Boolean criteria. About 80% of these people fail remission solely because of PGA. So because PGA is present in all 4 accepted definitions, we need to understand it more fully. What are patients trying to tell us through their global assessment of disease activity? We, among others, have studied this, and we have actually taken data from over 300 patients from our department and tried to establish the correlations of the patient global assessment of disease activity, so-called assessment of disease activity, with a number of parameters. And as you can see, the strongest correlations are seen between PGA and fatigue, pain, and function, irrespective of knowing whether these changes in fatigue, pain, or function are due to rheumatoid arthritis activity, sequela, or concomitant disease. There is also quite strong correlation with depression and anxiety. Both of these are much stronger than the correlations with indices of disease activity, namely the DAS28 3 variables with CRP or ESR, and the tender joint counts, and the correlation is much slower with more objective measures, much smaller, with more objective measures of disease activity like swollen joint counts, ESR, and CRP. On multivariate regression analysis, only pain, fatigue, function, anxiety, and tender joint counts are retained as, let's say, predictors or factors influencing the patient global assessment of disease activity, not swollen joint counts, nor the CIP. Very similar conclusions have been reached by different researchers, and they have been revised, or the literature had been revised back in 2016 by Nikiforov and colleagues, and they concluded from the existing literature that joint counts and acute phase reactants are not strong drivers of PGA, that in several studies, pain is the single main driver of the patient global assessment and may explain up to 75% of the PGA score. Also, that psychological distress is an important driver of PGA, and that score are influenced by the different wordings used to place the question, asking the patient for their global assessment of disease activity. Now, when we have then conceived the possibility that the PGA should be taken away from the definition of target, that is driving immunosuppressive therapy, given its very small relationship with actual disease activity, we have been faced in that proposal with several questions that I will try to address with you here. One of them is that most probably the patient's global assessment of disease activity would be reflecting subclinical inflammation that was not captured by the number of tender joint counts, namely the 28 joint counts that are typically used for the DAS. We have addressed this question by examining carefully with ultrasound the number of patients in remission, in PGA near remission, and in non-remission. And not only the joints, and 44 joints were assessed by ultrasound, but also tendon sheets and bursa, including, of course, the feet. And what we have concluded is that the level of inflammation examined by ultrasound is quite similar in patients who are in 4 variable full Boolean remission and those who fail remission solely because of the patient global, both of them being quite different from those patients who are in non-remission, who show considerable disease activity as expected. Similar conclusions have been reached by another group, namely in this study by Nakabo et al. They have also looked at the ultrasound of metacarpophalangeals, metatarsalphalangeals, wrist and ankles bilaterally in 400 patients with rheumatoid arthritis, and concluded that a high patient global assessment of disease activity did not reflect subclinical sonographic synovitis. Other studies have reached similar conclusions, namely other groups using also MRI of the hands. So to the question, does PGA, a high PGA, in people who are otherwise in remission reflect subclinical inflammation? I believe that we can superiorly answer, no, this is not the case. Despite this, some authors, namely from the group that have proposed the definitions of ACR and EULAR, argue that most probably PGA would still predict structural damage because it ought to reflect inflammation that we are not accounting for. We have studied this by approaching the question by individual patient analysis from 11 different trials in rheumatoid arthritis, where Biologic is very close to 6,000 patients. And we have seen that the combined meta-analysis shows absolutely no difference in the rates of good radiographic outcome as measured by the modified joint score between patients who are in full 4-variable remissions and in patients who fail this status just due to a PGA, so they are in PGA near remission. The rate of good radiographic outcome is similar, as we expected from the evaluation of disease activity, both clinically and ultrasonographically. In these patients who fail remission just due to PGA, and PGA can be as high as 10 out of 10, in a sizable proportion of these patients, PGA at 6 and 12 months was not a statistically significant predictor of radiographic progression, over 2 years. So to the question, does it predict structural damage? The answer, we believe, the best to our knowledge is no, it does not. So in fact, if we look at this group of people who are in PGA near remission, there are a number of aspects that need to be reconsidered. Namely, that they have no inflammatory activity. I believe that this is proven enough now. That there is no higher risk of structural damage, and still we are considering them as being in non-remission and proposing that they have incremental immunosuppressive therapy, that they have, however, high disease impact. So these aspects obviously put these patients at the risk of overtreatment, because if they have no inflammatory activity, how can we expect them to improve and to benefit from incremental immunosuppressive medication? But on the other hand, it also should call our attention that these patients still have unaddressed impact domains, and which is related and is reflected by their PGA. And they obviously, these impact domains deserve attention, even if the disease is already under control. So perhaps this is not a major issue if this is not a common problem, but it happens that it is. In the clinical practice, and we have studied 12 clinical cohorts, over 23,000 patients with rheumatoid arthritis, 12% of them were in 4 variable Boolean remission, 19% failed remission just because of PGA and would be exposed to overtreatment, whereas 69% were in non-remission and, of course, needed additional therapy. If we look at clinical trials, very similar numbers come up. The rate of remission is higher, 23%. The percentage of patients in these 11 trials that were in near remission is exactly the same as we saw in the clinical cohorts. And of course, the number or the percentage in non-remission is smaller. So we believe that actually, if we look at these aspects, we have to recognize that this is a very important status to be considered, as it affects 19% or very close to 19% of all patients with rheumatoid arthritis, and as many as 45 to 60% of all those who are otherwise in remission and have had sufficient immunosuppressive therapy. Another issue that has been raised is that clinicians are wise enough not to treat patients whose PGA is not associated with increased disease activity. Although we would expect that this wisdom should be brought into treatment recommendations, we also have evidence that this is not the case. Namely, for instance, in this study, where they have looked at 164 patients with rheumatoid arthritis who were treated as usual with no specific attention to fibromyalgia until they were submitted to a fibromyalgia survey. And what the authors concluded is that there were no differences between the two groups in terms of disease duration, smoking habits, rheumatoid factor positivity, and the group without fibromyalgia actually had a higher rate of radiographic erosions than the group with fibromyalgia. Now, if you look at the DAS28, which was not available in every patient, the DAS was higher in patients with fibromyalgia, as expected. The tender joint counts were higher. The patient global assessment was higher and significantly so, but there were no differences between the two groups in swollen joint count and CRP. However, the percentage of patients receiving biologics, 64%, was higher in the group with fibromyalgia than in those without, meaning that the patient global and the expression of suffering by the patients also, of course, impacted upon clinicians and led them to use more immunosuppressive agents. Similar conclusions were taken from a more recent paper from Norway, and they have looked at 203 DMARD-naive RA patients who were submitted to this Arctic trial with very stringent treat-to-target protocol over 2 years. And they compared in the end patients who had achieved a full variable Boolean remission according to PsA and SpA, with those who missed it due to a tender joint count higher than 1 or a patient global assessment higher than 1. Comparing these two groups, full remission versus those who failed it due to tender joint count or PGA, there was no difference in terms of musculoskeletal ultrasound, as we had found before. There was also no difference in terms of hands MRI, namely in terms of synovitis, bone edema, or tenosynovitis. However, the percentage of patients receiving biologics was different, 23% in those who missed remission due to tender joint counts or patient global versus 16%. An excess of 7% of patients on biologics in this PGA or tender joint near a remission group with an odds ratio of 3.6 for receiving biologics in comparison to the group who achieved four variable Boolean remission. So we believe that in looking at all these data, the conclusion that we need to reconsider the target we use to immunosuppressive therapy imposes itself, because it seems obvious and well demonstrated to us that we are putting a lot of these patients at the risk of overtreatment. Now, why do we need the target? The reason for this, I think, is quite well established, that by having a target, we pursue a status of disease that will result in better outcomes for our patients, both at the short and at the long term. Why should it be ideally a state of remission? Well, because remission provides the best possible chance of avoiding progressive structural damage and long-term disability. So the issue, we believe, is that we should focus on deciding which definition of remission best serves this purpose while providing to the patient the best immediate treatment and satisfaction of their needs. And we have recently looked at individual patient data meta-analysis to try and respond to this question. Over 4,000 people with rheumatoid arthritis, and we have compared the 5 possible definitions of remission. The Boolean from 2011, the Boolean from 2022, PGA less or equal to 2, the CDI, the SDI, and our own proposal, the 3 variable remission, equal to the Boolean 2011, excluding the PGA from consideration. What we have seen in this population is that the rate of remission is much higher with the 3 variable remission, and as expected, than with any of the other definitions, meaning that if we use the 3 variable remission, 56% of these patients would not need an incremental immunosuppressive therapy as compared to 75% if we use the Boolean definition. However, for patients who achieve these definitions, the rate of good radiographic outcome during the second year of the trial is very, very similar. And so suggesting that those who receive incremental treatment because the Boolean definition was used will actually have no major benefit. And if we try to look at the definitions that best predict the radiographic progression or its substance, although none of them is really good, the 3V remission definition scores the best, with 51% predictions being correct, as opposed to around 39% for the Boolean definition, the most stringent definition of them all. In this particular population, I'm using it as an example. If we use the 3 variable definition versus the Boolean definition of 2011, we'd have that 694 patients who would avoid incremental immunosuppression, while 150% would have some radiographic damage accrual. If the comparator was the more recent Boolean definition by PsA and SpA, 398 patients would avoid incremental immunosuppression by using the 3 variable definition, 88 of which, of whom would have a radiographic damage accrual. Now, certainly, we would all like to try and prevent this X-ray progression, and we hesitate in choosing the 3 variable definition because of that. But as a matter of fact, we can't do that. We can't avoid this radiographic progression. And the reason why is that we can't reduce inflammation when it is already absent, as we have demonstrated for the 3V definition. We can't reduce the PGA with immunosuppression if the high PGA is not due to inflammation. And even under the most stringent definition, the 4V Bullion definition of 2011, yet over very close to 17% of all patients still will have radiographic progression. So we really believe that the definitions of target need to be reconsidered. Essentially, because patients in PGA near remission are, for all relevant aspects in terms of disease activity, similar to being in remission. And this is encompassed, this group, by the 3 variable remission definition, which we propose should be adopted. In this case, the decision to maintain or increment the immunosuppressive therapy will be moved upwards in the scale, separating those who still have disease activity from the biological point of view from those who do not. This would avoid the risk of overtreatment associated with the PGA. But of course, the other aspect is still unaddressed. The unaddressed impact domains of patients who have a high PGA. Should we ignore the impact upon the patient's life? Of course not. We need to take care of that. So while taking the PGA away from the definition of the biological target, we propose that another target, the impact target, is considered in parallel. They are related, but they are not absolutely the same. The biological target would be defined by the 3 variable remission, which would avoid overtreatment, and we need an impact target that is at the same time simple, comprehensive enough to cover all domains of disease impact that are relevant for the patient and informative to allow the clinician to select adjuvant therapy. So our suggestion is that we should consider the impact target when the biological target is reached or about to be reached. We should be able to screen for patients with significant impact, identify the unabated domains of impact, and select adjunctive interventions that are appropriate or most appropriate for that particular patient. How can we screen for patients with significant impact? Our proposal is that the best suited instrument for this purpose is the PAS. The PAS is a very simple, classic looking approach to the medicine, or it relates to our classical approach to medicine. It's based on this question. Consider how your rheumatic disease has affected you during the last week. If you were to remain in the coming months as you have been the last week, how would you rate your conditions? From 5 points, from very bad to very good. We have demonstrated that this has a very close relationship with disease activity, and also that this is very sensitive to change. It is valid, sensitive to change, reproducible, and physical instrument to screen for patients who have excessive impact, meaning impact that is not in agreement with the status of low disease activity or remission. How can you identify the innovative domains of impact? We believe that the rheumatoid arthritis impact of disease score is best suited for this. It was developed in cooperation with patients who identified 7 major domains of disease impact: pain, function, fatigue, sleep, physical well-being, emotional well-being, and coping. This can all be scored with a numerical rating scale of 0 to 10, and we have demonstrated that considering each of these dimensions separately also is valid, it is feasible, it is sensitive to change, and reproducible. So in practice, we believe that an improved strategy based on treating to target could be developed, and this would be served by the dual target strategy. Basically, we suggest our patients will start by being treated, and obviously, usually they start by active disease, receiving the IMIDs, and being assessed as in treat to target strategy every 3 to 6 months, but taking into account a biological target and an impact target. The biological target being represented by the 3-variable remission, the impact target by the PAS. And if the patient has not satisfied the PAS target, then the RAEs should be considered so that we know which domains are unabated and need for adjunctive therapy. So in a way, this is also personalized medicine for the patient individual in front of you, taking into account his individual needs and feelings, although not still considering their genes. So to do a target strategy, we believe, would reduce the risk of overtreatment associated with the current recommendations, improve the target of immunosuppressive therapy, making it more valid, highlighting the importance of disease impact in the eyes of the clinician and the eyes of the patient and the healthcare team, promote patient-centered care and patient satisfaction and enjoyment of life while being still robustly evidence-based and easily feasible, we believe. I end by thanking my co-workers and also the international partners in this research, and we're very happy to take any questions that you may have. Thank you.